Good afternoon, everyone. I'm Brett from Taiwan, National Taiwan University Hospital. I'm a medical oncologist. So I have been here and listened to the morning session from public health and screening. So let's jump to the treatment perspectives of breast cancer. I was tasked to give an update on HR-positive, HER2-negative metastatic breast cancer. You can see I will start from this ABC7 really complex algorithm, but to keep the time, and also I found out that there will be later sessions on ADCs and chemo. So for this session, I will be diving deep into endocrine therapy only. So this will be a landscape introduction of the recent advancements of endocrine-based therapy in HR-positive, HER2-negative metastatic breast cancer. So we all know that the standard first-line therapy is an AI plus CDK4/6 inhibitors, unless the patient has recurred rather early during under adjuvant endocrine therapy. This is because we have multiple first-line randomized controlled trials showing that the addition of CDK4/6 inhibitors in the first line roughly doubles the PFS, hence the hazard ratio around 0.5 to 0.6. Unfortunately, we know that only 5, maybe to 10% of patients are long responders. So patients do eventually progress after treatment on AI plus CDK4/6 inhibitors. So what kind of advancements have we had in the past 1 or 2 years on how to treat these endocrine refractory patients? So I'd like to begin. What are the mechanisms of endocrine resistance? We can start from, this is an old study. This is from MSK Impact panel. So they did a tissue-based targeted NGS panel on over 1,500 tumors. And some of them, 800 were treatment naive, and around 700 were after endocrine therapy. So you can clearly see from the figures, after endocrine therapy, we get more ESR1 mutation that we know already. We also get more MAPK kinase pathway dysregulation and some transcriptional regulation upregulation. So to put things into a clearer graph, again, we get ESR1, but there's still MYC and other TF dysregulation, other pathway crosstalk, and of course, there are still a certain proportion of tumors we cannot define or characterize the specifics of endocrine resistance. So this is translational research. But from a treatment perspective, how to put this graph into a treatment perspective. So I give you another graph. So this is a simplified mechanism of endocrine resistance. On the left side, you can see drivers of ER-dependent resistance, hence ESR1 mutation. By gaining or acquiring ESR1 mutation, the tumor is still governed by the ER pathway, but no longer responds to estrogen deprivation. So it is ER-dependent, but estrogen-independent resistance. On the right side of the figure, you find many alternative pathway activations, and we can talk about those targeted therapies later. So the first part of my presentation will be focused on ER-dependent resistance. And you can see from the box that this is majorly the most advancement in the past 3 to 5 years, moving from fulvestrant to oral SERDs, to normal SERMs, and to PROTACs. So let's begin. We know that ESR1 is a mechanism of endocrine resistance, no matter it's acquired or selected. And ESR mutation confers ligand-independent activation of transactivator functions. So the tumor still is ER-dependent, although it does not respond to AI. We know this already from the past. We know this for a long time. But we began with AI plus CDK4/6 inhibitors, right? So what is the prevalence of ESR mutation in the era of CDK4/6 inhibitors? So there are studies utilizing the Flatiron Foundation clinical genomic database. So lots and lots of tumors. And in this database, some patients were recurrent tumors, some tumors were de novo tumors, and some tumors had their NGS done in the first line, some had theirs done in the later line setting. So from this graph, you can tell, since they collected all those clinical data and also genomic data, we can do comparisons. So on the left, what is the ESR1 mutation prevalence if we compare primary resistance to secondary resistance? Before we see the results, we can guess that the longer the tumor is exposed to AI, maybe the higher ESR1 mutation prevalence. So it is definitely shown here on the left. On the right, what about the use of CDK4/6 inhibitors? Since the use of CDK4/6 inhibitors can prolong AI treatment periods, you can see from the delta, the ESR1 mutation prior to AI and after AI, or prior to AI plus CDK and after AI plus CDK, the absolute delta increases from 21% to over 35%. That means we are more likely to get ESR1 mutation in the era of CDK4/6 inhibitors. But what can we do about, how can we treat these ESR1 mutated tumors? In the past, we only have fulvestrant. And from the combined analysis of SOPHIA and INFECT, you can see that exemestane actually doesn't work at all in those ESR1 mutated tumors. But there is a certain activity you can find, fulvestrant retained partial activity against ESR1 mutations. So fulvestrant was our only weapon against AI refractory tumors. But there are also downsides of fulvestrant. We know that from cell studies that if you want to target ESR1, a higher IC50 is required. Well, we can do that in cell line studies. But since fulvestrant is injected intramuscularly, we cannot simply just give the patient lots and lots of fulvestrant. So there's a bioavailability issue. So due to the suboptimal drug concentration in our patients, fulvestrant isn't the perfect answer for ESR mutation. And the progress in this field in the past 3 to 5 years are oral SERDs, of course. So we have many, many trials of oral SERDs comparing them to standard of care endocrine therapy. Let me just briefly introduce some frontrunners. So this is not, I'm not trying to do cross-trial comparisons because you can see from the text that the EMERALD trial and the EMBER trial are different. They enroll different patient populations. The level of pre-treatment is widely different. But these are the first 2 successful phase 3 trials utilizing oral SERDs. And what have we learned from these 2 trials? First, if we target ESR1 wild-type tumors, actually, it isn't that oral SERDs aren't effective. They are effective. They are just as effective as fulvestrant, but not better. Also, I would like to point out the lower part of the Kaplan-Meier survival curve. We used to see that, okay, so if we get an ESR1 mutation, the tumor is more endocrine dependent and are better likely to respond to subsequent endocrine therapy. But I would still want to point out there's still a tail in these survival curves, meaning that even if the tumor is ESR1 wild type, there is still some patients or some tumors that respond fairly well to second-line endocrine therapy. We just don't know how to identify them. We don't know how to tease out the highly heterogeneous ESR1 wild type but endocrine-resistant tumors. So that's for ESR1 wild type. What about ESR1 mutated tumor? You can clearly see that oral SERDs are better than standard of care endocrine therapy in ESR1 mutant tumors. So elacestrant is better and imlunestrant is better. Again, I want to point out the top of the survival curves. Even by targeting ESR1, by the first scan, within 3 months, around 30 to 40% of patients progress. That means ESR1 is not a perfect biomarker, and we need other combination therapy to overcome this initial drop in progression-free survival. Lastly, I would like to just briefly point out an interesting signal from EMBER-3. We know that there are 3 arms in EMBER-3. There's imlunestrant, there's a control arm, and also they included arm C, imlunestrant plus abemaciclib in the post-CDK4/6 setting. We all know that imlunestrant plus abemaciclib is far better than imlunestrant alone. So I'm not trying to do comparison, but just look at the absolute PFS in the experimental arm. In patients priorly treated by CDK4/6 inhibitors, imlunestrant plus abemaciclib led to a PFS of 9 months. And also, in PI3K pathway altered tumors, but not with a PI3K inhibitor per se, but imlunestrant plus abemaciclib also had a PFS of 7 months, which I think is a good signal. Okay, so for this year at ASCO, we had SERENA-6. So this is the AZ compound camizestrant. So the study design was to enroll patients who have not progressed on AI plus CDK4/6 inhibitor, but had evidence of ESR1 mutation rising via ctDNA testing. So upon detection of ESR1 mutation, patients that did not have radiologic progression were randomized to camizestrant plus CDK4/6 inhibitors, or to continue the original treatment with AI plus CDK4/6 inhibitors. So you can tell from the study design, they were very ambitious. They're trying to answer 2 questions in one clinical trial, actually. They want to demonstrate the superiority of camizestrant, that's for sure, but they also wanted to test if biomarker progression, a treatment adjustment, not based on radiologic progression, but by biomarker progression, would lead to better outcomes. So they're testing 2 hypotheses in one trial. So let's look at the primary endpoint, the investigator-assessed PFS. Certainly, if you change the AI to oral SERD camizestrant, you get a better PFS, and the absolute delta is around 7 months. The hazard ratio is 0.44. Also, they reported PFS2. So camizestrant plus CDK4/6 inhibitors were still superior. But do you think that they answered the question on whether biomarker progression would be better? I believe maybe not so. Because if you look at the PFS2 more closely, you find that the subsequent treatment is highly imbalanced, and they did not offer crossover to camizestrant. So how can they answer this question? So that's one caveat of SERENA-6. Also, another big caveat is patients did not progress to be enrolled in SERENA-6, right? So they had to do routine NGS screening for ESR1 mutation every 2 to 3 months. So they initially started with over 3,000 patients. But look at the last numbers, only 300 of them were finally enrolled. So this approach actually only succeeded to enroll only 10% of patients with this biomarker-driven approach. Then if you look at the bottom of the slide, you can also find by detecting ESR mutation, some of the patients already had also concurrent radiologic progression. So that's also a problem. My personal thoughts, first, crossover to camizestrant was not allowed in the control arm. So I do not think, although SERENA-6 was reported in the presidential session in ASCO, so supposedly practice changing. But crossover to camizestrant was not allowed. So I believe that SERENA-6 actually did not provide robust evidence supporting endocrine therapy switch and molecular or biomarker progression rather than radiologic progression. Also, if you notice the control arm, they had, upon detection of ESR mutation, by keeping the same treatment strategy, continuing the same AI and the same CDK4/6 inhibitor, you still get a 9-month PFS. So why bother change? That's another huge question. And we all know that there are lots and lots of potential harms of ctDNA testing, just this more than cost alone. Like patients are anxious to get tests, and we know that over 50% of patients will never develop ESR mutation. They eventually will progress due to other resistant mechanisms. So although SERENA-6 is a successful trial, is this actually practice changing? I think we have to wait some more. Okay, again, moving on to ESMO this year, so update of this year, another oral SERD by Roche, also giredestrant versus standard of care endocrine therapy, both combined with everolimus in patients pre-treated with CDK4/6 inhibitor, but chemotherapy naive. For the sake of time, I'll just jump to the main conclusion. In ESR mutated population, giredestrant plus everolimus was clearly superior to standard of care endocrine therapy plus everolimus. So I think we can guess this. So this is not a surprise. And Because since in this trial, certain patients got exemestane and certain patients got fulvestrant, and the author also kindly provided subgroup analysis showing that the benefit of giredestrant is not just against exemestane alone, but also is superior to fulvestrant as well. And if you wonder what happened to the ESR1 wild-type tumors, again, just as I mentioned, oral SERD were effective, but not more effective than standard of care endocrine therapy. So you get the hazard ratio of around 0.8 to 0.9. Lastly, novel endocrine agents. What do we have next? So PROTACs, proteolytic targeted chimeras. So the front runner is ARV-471, vepdegestrant. So it combines ER, leading it to E3 ligase, facilitating ER degradation. And the global phase 3 trial was reported in ASCO this year, the VERITAC-2 trial. So again, very, very similar patient population. Patients were treated with endocrine therapy plus CDK4/6 inhibitors, but no prior chemotherapy was allowed. Patients were randomized to vepdegestrant or fulvestrant. So very similarly, in ESR1 mutant tumors, a novel endocrine therapy was better than fulvestrant. But in the ITT population and also in ESR1 wild-type tumors, the benefit could not be shown. Okay, so that's just a brief overview of the progress we made in the past 2 to 3 years in novel endocrine backbone agents. And my key takeaway would be all these agents, no matter which oral SERD or PROTACs, they all showed modest single-agent activity and outperforming fulvestrant in ESR1 mutated tumors. And if you combine these novel endocrine agents with other targeted therapies, you can expect a better treatment efficacy. But unresolved questions: how do we differentiate between these agents? Will certain oral SERD be more effective against a certain ESR1 mutation? And which drug will be the better backbone, the safer backbone to do combination with other targeted therapies? Another important question, since I know that oral SERDs are already available in Hong Kong right now, it's not available in Taiwan, but what do you think? After progression on an oral SERD, if the tumor, you presume it to be still endocrine sensitive, what endocrine backbone would you use after oral SERD? So that's another unresolved question. Finally, we're seeing definite progress in the past 3 years regarding a novel endocrine therapy backbone. But have we reached the ceiling? We can see from these window of opportunity neoadjuvant trials that oral SERDs and PROTACs actually already have maximal ER degradation ability and can cause maximal Ki67 suppression. So have we reached the ceiling already? What's next for ER pathway blockade? So that's another unmet need. Okay, so that's all my thoughts for the progress we had regarding ET backbone. So the remainder of my presentation will be on targeted therapies. You can see from this slide, we have CDK4/6 inhibitors for sure. We have targeted agents targeting PI3K, AKT, mTOR pathway. Okay, so first let's begin with CDK4/6 inhibitors. Would continuation of CDK4/6 inhibitors beyond progression provide benefit? So this was a debate in the past 3 years, I believe. And we are not used to continue certain drugs beyond progression. From colon cancer, we know that the continuation of bimekizumab beyond progression provides a PFS benefit. We also know from a German trial that continuation of trastuzumab beyond progression will definitely lead to PFS benefit. Why is this? That's because when a patient or a tumor progresses on combination therapy, it does not necessarily mean that the tumor is resistant to both treatments. So what about CDK4/6 inhibitors? When tumors progress on CDK4/6 inhibitors, do they have resistance to both AI or ET plus CDK? We can have a hint from PALOMA-3. So in PALOMA-3, patients were randomized between fulvestrant plus CDK4/6 inhibitor palbociclib or fulvestrant alone. And they had paired liquid biopsy, so before treatment and after progression. And you can just get a generalized view on this graph here. You can first find there is RB1, So we know RB1 is a specific resistant mechanism to CDK. But if you look at the remainder of the figure, actually I would say the pattern of mutation acquisition is actually similar across both arms. And what does this mean? It means that progression is largely not driven by resistance to CDK. It's actually driven by resistance to the endocrine therapy backbone. So we have phase 2 and phase 3 trial testing this. Continuation of CDK4/6 inhibitors beyond progression. Some succeeded, some failed. But most trials utilizing a switch in CDK4/6 inhibitors succeeded. And for cell cycle inhibitors, we can look forward to selective CDK4 inhibitor, atirmociclib. They have phase 3 trials ongoing, and we expect readout in the further 2 to 3 years. Lastly, on the PI3K AKT-mTOR pathway, we know that this pathway is important in luminal cancers, and we have lots and lots of targeted therapy targeting this pathway. First, everolimus. We know from BELARO-2 that it provided a PFS benefit in the later line setting. And recently, I just mentioned about Evera, right? So in the control arm, fulvestrant plus everolimus also had a PFS of around 5 months. So I think that's acceptable. That's acceptable. But we know that everolimus isn't super effective in PI3K CA mutant tumors. It is still effective, but less effective compared to PI3K wild type tumors if you compare the hazard ratios. So we need something more. So later we have alpelisib, so the first alpha-specific PI3K inhibitor that succeeded. And from BYLieve, we know that in a post-CDK4/6 inhibitor setting, we get around 8 months of PFS. And in the novel trial, which I think is super important because we have new PI3K inhibitors that have a widened therapeutic index, allowing them to be combined with CDK4/6 inhibitors. So in the INAVO 120, inavolisib plus palbociclib plus fulvestrant, a triplet combination for the first time, was compared to palbociclib plus fulvestrant. And you can see the good separation of the PFS curves and an absolute delta of 7.7 months in PFS gain. Also remarkably positive, statistical significant in overall survival gain. And lastly, in ESMO this year, we have a new agent, gedatolisib. So it is a pan-PI3K plus mTOR inhibitor. What makes it special? Because we know that actually for cells, normal cells, they rely on this pathway. So the PI3K pathway actually is important in physiology. So there are many feedback mechanisms. And if you just block one node using a selective PI3K inhibitor, after a certain period of time, tumors may progress via feedback mechanisms. And if you give a gedatolisib, which is like a vertical blockade, it might lead to better efficacy. And in ESMO this year, the triplet combination of gedatolisib plus palbociclib plus fulvestrant was superior to fulvestrant alone. So you can see these two Kaplan-Meier survival curves. Both gedatolisib combinations were superior. And I would say even superior in those patients who were pre-treated with palbociclib. So that's a first signal of continuation of palbociclib beyond progression leading to benefit. And lastly, what about the toxicity profile? So we mentioned 2 triplet combos. But again, as I mentioned, with the advancement of new targeted therapy and a widened therapeutic index, hyperglycemia seems no longer to be of an issue. So we're rather safe to give the INAVO 120 or the Victoria 1 triplet combination. Lastly, just a brief mentioning of capivasertib. So in the CAPItello-291, also in an endocrine resistant setting, patients were randomized to capivasertib, the AKT inhibitor, or placebo, both plus fulvestrant. And you can see in those pathway-altered tumors, treatment with capivasertib led to PFS benefit. And what's remarkable of capivasertib is not only is it effective in PI3K alterations, it's also effective in AKT alterations and PTEN alterations as well. Again, comparing all these side effects, You can see, of course, rash is an issue for capivasertib, but they are still quite manageable. So these are the targeted therapy advancements we had in the past 3 years. So key takeaways. New PAM inhibitors have a widened therapeutic index, allowing for triplet combinations. And we can expect more after progression on CDK4/6 inhibitors. Unresolved questions will be, how do we compare these individual agents? There are no head-to-head comparisons, and we do not know which agent is better in terms of efficacy. So this is the landscape in the past 3 years. For a treatment-naive patient, we can start endocrine sensitive. We can start with AI plus CDK. For endocrine-resistant tumors, without PI3K mutations, we can give fulvestrant plus CDK4/6 inhibitors. For patients matching the INAVO 120 trial improvement criteria, namely those with PIK3CA mutation, we can give the triplet. After progression on CDK4/6 inhibitors, we can give monotherapy, but most importantly, we can give combination therapy. I know this is a busy table, but for the final 3 minutes or so, I would like just to give you a practical tip of how I look at this busy table. So how can we personalize these all treatment options? So we know that from my prior talk, we can see that genomics biomarkers matter. But also, I believe I would like to very stress on clinical biomarkers. So what are genomic biomarkers? It's for sure we need to have NGS done to get PIK3CA mutation or AKT pathway alterations or to detect ESR1. So we know that already. But I would like to place emphasis on clinical biomarkers as well. We know, this is just a graph, we know, I hope there aren't lung cancer specialists here, right? So we are Breast Cancer Foundation. I would regard lung cancer as a stupid cancer, because if you think of EGFR mutated lung cancer, it's always dependent on EGFR mutation. So one targeted therapy against EGFR1, after acquired resistance, another targeted therapy. So our lung cancer colleagues they have an easy life because they can give targeted agents in sequence. Okay, just a joke. But luminal cancers, I believe, are smart cancers. So they are highly heterogeneous, and they are also not just those genomic biomarkers, right? So ER signaling, per se, remains an important part. So we need to estimate endocrine sensitivity, and we can do that based on the PFS of prior CDK4/6 inhibitors, so that's important. Also based on the distribution of the metastases, right? So only soft tissue mets will be more indolent. If the patients have bulky liver mets, it will be more aggressive and more endocrine resistant. Also, the ER level also matter as well. So if we look at all this, we need to define endocrine sensitivity, right? So doctors are a bit like fortune telling. This is also a big thing in Hong Kong, right? So patients get fortune telling. So doctors have to observe these tumors and guess the biology and see if the tumor is indolent or more aggressive. And why is this important? Why? Because we know that for indolent disease, tumors have more chance, patients have more chance to get additional therapies. But for visceral crisis and aggressive disease, they get less chance. So maybe for an indolent disease, over 3 lines of endocrine therapy. For aggressive disease, maybe 1 or 2 lines. For visceral crisis, maybe no, or only 1 chance to get endocrine therapy. So what are my choices? For endocrine sensitive tumors with slow progression, we can give these treatments in sequence. So there are multiple options, they are all feasible, right? But if the tumor has rapid progression after CDK4/6 inhibitors and have only 1 more chance of doing another endocrine therapy, I will leave it to the targeted agents like PIK3CA inhibitors and AKT inhibitors. Finally, for those with endocrine resistance and PIK3CA mutation, upfront triplet can be used, and these patients have less treatment window. So we give the most strongest combos up front. So my last slide, the take-home message. We know that in the past 3 to 5 years, what progress have we made? We have the efficacy of endocrine-based therapy was improved by refinement of the endocrine backbone. So we have oral SERDs, we have PROTACs, and also by the combination of novel targeted therapies. But more importantly, I believe that we should tailor our endocrine-based therapy by drug selection based on genomic biomarkers, but also by estimation of endocrine sensitivity. such as disease tempo, site of metastasis, and level of ER expression. Thank you.
Thank you, Dr. Hong. Would you please